All right, so this is one of the questions from my live class. So a 28-year-old female presents to clinic with mild non-specific chest pain after a 3-hour flight, and that is deliberately there to tingle your spidey sense into thinking this is pulmonary embolism. She has no leg swelling, no tachycardia, no history of clots. Her Wells score is 0. And generously, they also explain what that means, which is low pretest probability of pulmonary embolism. And even more generously, they tell you that it is roughly 1%. A defensive clinician orders a D-dimer. The test has a sensitivity of 95% and a specificity of 50%, so that of flipping a coin. It comes back positive. Oh no. So now the question is, what informs your decision that this result is probably an error, right? And it probably is. Like the step one of this question is recognizing that this result that came back positive is probably an error, right? The right thing to do would have been not ordering this test because Wells score is essentially like 0. So the pretest probability of this being a pulmonary embolism was low. I mean, they could have been more explicit and then told you that there is no hypoxia, there's no shortness of breath, there's no pleuritic chest pain and all that, right? But then they told you that the Wells score is 0, so that's there. The first option says because it is positive, and positive predictive value is only 1.9%. Okay, so we'll have to check if it is 1.9%. So we'll have to construct a 2x2 table here. The positive result is completely useless and forces an unnecessary high radiation CT pulmonary embolism. I mean, the way the premise of this option is very right? Because now D-dimer is positive and you cannot ignore that. You'd apply Bayes' theorem here and you'd include D-dimer being positive as the new piece of evidence in calculating the probability of this 28-year-old female having a pulmonary embolism, right? Previously, it was 28-year-old female who did not have tachycardia, probably did not have hypoxia. Wells score was 0. What is the pretest probability of pulmonary embolism? Like very, 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 very low. So the right thing was not to order a D-dimer and clinically rule out pulmonary embolism, but D-dimer is ordered and it came back unfortunately positive. So that is a new piece of information now, and Bayes' theorem tells you that you have to apply that evidence to come up with a new probability, and that probability would be slightly higher now that D-dimer is positive. So you cannot ignore it. You'd have to order a pulmonary angiogram now. And option B is if tests were negative, the negative predictive value would be very high. We would have to test that, and then the same 2x2 table will give us negative predictive value also, allowing you to safely rule out pulmonary embolism without CT scan. Now, this is true, right? I mean, you can also sort of guess what positive predictive value and negative predictive value of this test would be, because it is a high sensitivity test. So you would think that its negative predictive value would be high. If it is a high specificity test, then you would have thought that its positive predictive value would be high. It is a very, the specificity of this test is that of flipping a coin. So positive predictive value of this test would obviously be low, but then we will use a 2x2 table and then figure out what the positive predictive value exactly is. Option C is high sensitivity tests are for ruling out disease when negative, not ruling in disease when positive. That is correct, right? I used to remember SNOUT from first aid. So sensitivity, rule out disease, right? And then one modification to that can help you sometimes is if you add an AND to it. So high sensitivity, negative predictive value is high, and then it is to rule out disease, right? And option D is because a positive D-dimer cannot be safely ignored once ordered, you will proceed with the definitive imaging, which is CT-NG. That's correct. So correct answer has to be E. I'll skip the voting on this one, and I'll directly show you the answer, right? So the answer says, well, it reads, statistically speaking, your job as a doctor is to assign pretest probability of having a particular disease to a patient based on various characteristics, right? The characteristics here were that she did not have tachycardia, probably did not have hypoxia, probably did not have any EKG changes. Well, score was 0. At that point, you should have just clinically assigned very low pretest probability and ruled out pulmonary embolism. But whoever did this did not think of the scenario in that regard. So they ordered a D-dimer, right? Now, because the option talks about positive predictive value and negative predictive value, we know positive predictive value and negative predictive value are talked about in the context of the test already being ordered and resulted, right? Which is true here. So the test is ordered, the test has resulted. So now you want to calculate this, and it's very easy. Positive predictive value is like everything. The formula for sensitivity, specificity, positive predictive value, and negative predictive value is truths on the top divided by everything else, right? So truths on the top, you just need to know what population are we talking about, right? For positive predictive value, we are talking, the population we're talking about is all positives, right? If you calculate if you construct a 2x2 table, right, all positives is this row, correct? So if you just do the maths there, true positive, so truth on the top, this is true positive, right? People who have pulmonary embolism and then tested positive, they are true positives, and divided by everything else, all positives, right? And negative predictive value would be truth on the top divided by everything else. What is the population we're talking about when we're talking about negative predictive value? Everyone who is negative, right? Not relevant to this question, but what is the population that we're talking about when we're talking about sensitivity? Everyone who has disease, right? And specificity, everyone who is healthier, who does not have the disease, right? And there also will be truth on the top divided by everything else, divided by everything else. The option is always, like, the answer is always truth on top divided by everything else, right? For 4 things: positive predictive value, negative predictive value, sensitivity, and specificity. All right, that's a detour, but then now you calculate positive predictive value and you get 1.88%, right? What does that translate into? That translates into 100 minus 1.88, so 98.12% chance that this result is a false positive, right? Which is a direct consequence of ordering a test with low specificity and a low pretest probability. That is the most dangerous combination, right? If you order a test with low specificity in a population where pretest probability is low, there is a chance that your positives would be, this very, very, very big chance that your positives would be false positives, right? Yeah, so the other thing that I've seen a lot of people make mistake is they think that this is negative predictive. It is not negative predictive value, right? Because if you calculate negative predictive value, truths on the top divided by everything else, truth is, in the population we're talking about, negative predictive value is everyone who tested negative, so true negative divided by all negatives, it's 99.90, right? Negative predictive value is the probability that a patient does not have the disease given the negative test result, right? Positive predictive value is the probability that the patient has the disease given the positive test result, right? Now, this patient had a positive test result. Negative predictive value has no relevance here, all right? If the test were negative, then we would be 99.9% sure that she did not have pulmonary embolism. Now, because this was, like, we talked about positive predictive and negative predictive value, right? One thing to remember there is that when you compare them to, like, sensitivity and specificity are properties of a test. It does not matter where you apply this test to, right? That is not true for positive predictive value and negative predictive value. Positive predictive value and negative predictive value are properties of the test combined with the pretest probability, right? And that is why, like, Bayes' theorem applies there, right? So you have to assume or at least like devise for yourself a pretest probability before you go and test your hypothesis, right? And that is why you take history and do physical examination. You talk to the patient before ordering tests, right? So the lesson here is, if you are ordering a test and the test has low specificity, right, then the pretest probability of that specific disease better be high in that population, only then you order that test, right? Or else you're better off not ordering that test. If your pretest probability is low and the specificity of that test is low, there's no point ordering that test, because if both are low, right, then positive predictive value is so low that you better be hoping that the test will come out negative. If that test is positive, then you are in a big time trouble. All right, so hope that clarifies something.